From the Department of Psychiatry, Dr. will be presenting a case and a discussion around that on traumatic brain injury. Traumatic brain injuries are common and they lead to a lot of cognitive problems like attention deficits, memory difficulties, and so on. And most treatments are very good, but they're generally not very effective. They are going to describe a novel treatment modality which shows a lot of promise, and so I request Dr. Verma to start.
Thanks. Good afternoon, everyone. We will be presenting the CCR of Department of Psychiatry under title Harnessing Neuroplasticity, Transcranial Direct Current Stimulation in the Rehabilitation of Traumatic Brain Injury. This is about the content of presentation. I will be introducing the topic, followed by the clinical case presentation and management by Dr. Merlin, neuroimaging by Dr. Shweta, Department of Radiology, tDCS and evidence by Dr. Hemant Chaudhary, followed by the conclusion remarks by Dr. Professor Rohit Verma. Traumatic brain injury is a major public health problem worldwide as well as in India, as the data shows that around 10 million people in world and around 2 million people, 2 million people in India suffers from traumatic brain injury each year. The data shows that it is estimated that in our country nearly 2 lakh people die every year due to TBI. The global burden of disease study in 2019 showed that around 11.1% increase in the age-adjusted incidence rate of TBI and 22.4 increase in age-adjusted prevalence rate in India. But the Western data has shown that there is a decrease in incidence and prevalence of this traumatic brain injury. Those who survive, it has shown that the effect of TBI on injured patient and their families is profound. Most of the survivors end up with a chronic disability, physical disability like difficulty in walking, there are locomotor issues, there are gait disturbances, dizziness, and neuropsychiatric symptoms such as agitation, aggression, behavioral symptoms, as well as many are unable to join their job again. The cognitive impairment of all these consequences, cognitive impairment has been found to be associated with significant impact as compared to other disabilities. Cognitive impairment after TBI is associated with the quality of life even after accounting for TBI severity, premorbid or comorbid psychiatric symptoms and sleep disturbances. The cognitive impairment plays a key role in disability after TBI, particularly for individuals who are dependent on their families to take care of themselves. The cognitive problems predominantly seen includes deficit in information processing, speed, attention, executive functioning, and memory. The other reported are reading and writing difficulties, comprehension difficulties, followed by problem solving, organizing, as well as the impairment in judgment and safety skills. The current treatment options are either we have drug therapy or we have non-pharmacological intervention in the form of cognitive rehabilitation. The issues, the drug which are commonly used are catecholamine stimulants such as like methylphenidate, amantadine for attention and processing speed, cholinesterase inhibitors such as donepezil for memory impairment, and the evidence also supports the newer agents such as citicoline. But major of these agents, there are lack of control studies that demonstrate the use of medication to enhance recovery. There are no FDA-approved drugs to use for such treatment. Whenever drugs are used, they are mostly useful in the neurobehavioral symptoms rather than treating the cognition. Also, these patients are highly sensitive because of the insult occurring in due to neurotrauma injury. They are more sensitive to the side effects of psychotropics. Because of that, the option of using drugs is limited. And also studies have shown that there are inconsistent cognitive improvement shown with these drugs. The cognitive rehabilitation interventions such as attention training, memory exercises, problem solving, and executive function trainings are available, but they have limited benefits and often do not translate to daily life. The studies have shown that there are these, because the brain injuries have complexity and heterogeneous in nature, it becomes difficult to standardize the treatment and the rehabilitation. There are lack of trained and therapists and limited access to these therapists and services. Usually the cost associated is very high and the long duration of treatment, it becomes difficult to practically translate it to be beneficial in the daily life. The studies have shown that around only 23.7% of moderate to severity by patient, often they have reported that only 23.7% recovered with this inpatient treatment. In the recent years, the data is generating about the role of transcranial direct current stimulation, particularly in cognition, in neuropsychiatric disorders such as ADHD, stroke, dementia, and depression. We will be presenting a case where a patient had a lot of cognitive dysfunction, which was managed with the help of transcranial direct current stimulation. Briefly about the services which are available in the department. These are interventional psychiatry services. We are offering like modified ECT, virtual reality therapy, and transcranial direct current stimulation as well as TMS services in the department. So I would request Dr. Merlin to present the case.
Good afternoon, everyone. Moving on to the clinical case presentation. The index case is a 30 years old unmarried male studied till 12th standard, not working, belonging to a Hindu nuclear family of middle socioeconomic status. And, coming to the premorbid temperament, patient had a stable mood prior to the onset of illness with adequate social interaction, normal sleep-wake cycle, appropriate self-care. There was no history of any psychiatric or medical illnesses. The history began in October 2014 when the patient, while riding on a bike, underwent a road traffic accident. There was documented history of loss of consciousness and ENTG. Patient was subsequently taken to the trauma center where first aid and resuscitation was done, and patient was intubated with a poor GCS score. Patient immediately, in the first few hours of management, underwent left frontotemporal decompression craniectomy for an intracranial bleed, the details of which will be presented by Dr. Shweta in the imaging findings. There were other associated injuries as well, including a degloving injury in left forearm and arm and a right forearm fracture. Patient was managed surgically for the same during the same surgical intervention. In the next 29 days, patient gradually regained his consciousness and continued receiving an ICU care for 3 months. During this period, patient had new onset of generalized tonic-clonic seizures, for which the patient was started on valproate and phenytoin. Over the next year, patient had his tracheostomy removed in the early months of 2015, following which family members reported that patient had significant difficulty with speaking and would only use monosyllabic and bisyllabic words. Patient was unable to remember most of his family members and known members and close people, except his father, for whom he'll nod and would be able to say the word. Patient also had difficulty standing upright and walking and had a restricted range of motion in arms, so needed significant care for activities of daily living. Patient was also unable to communicate his food and bathroom and other urgent needs during this period. He continued having seizures once in 2 to 3 months, following with anti-epileptic medication was optimized, and subsequently patient has been seizure-free for the past year. From 2015 to 2019, patient's speech gradually improved. Patient was able to repeat most of the words. He still had significant difficulty remembering past events, and he also had difficulty recalling names of familiar persons and objects. Even when patient was cued or given repeated cues, patient would not be able to retain the names after a few minutes or hours. Thus, he had difficulty retaining new information. During this period, he also developed a lot of mood changes in the form of irritability and aggression on trivial provocation, often leading to shouting, screaming, as well as throwing objects on the floor. He needed help with most activities of daily living, and including both the motor components as well as with the routine itself. He continued having difficulty walking, which gradually improved. He continued walking with a limp and had weakness in his left lower limb. He would be able to follow most simple instructions, but after repeated cueing. Now, before moving on to the neurocognitive assessment, we will be going through the brain imaging findings, which Dr. Shweta will be presenting.
Good afternoon, everyone. This is the first image we have of the patient, which is from October 2014 at the time of trauma, which is showing hemorrhagic contusions in bilateral temporal lobes, left parietal and left frontal lobe. There was significant mass effect, which was seen as a midline shift, for which decompressive craniectomy was done. These are the hemorrhagic contusions over here. This is the frontal hemorrhagic contusion, largest was in the left parietal lobe, left temporal lobe. And this is the last imaging we have from July 2017, which is showing post-cranioplasty changes. And there is gliotic changes corresponding to the areas of hemorrhagic contusions, predominantly in the left temporal lobe.
Continuing on to the neurocognitive assessment and presentation in psychiatry OPD, patient presented to our OPD in 2020 for the first time, where a neurocognitive assessment was done using the following scales, and also a brain imaging was attempted with functional near infrared spectroscopy. We'll go through the details of the same. Montreal Cognitive Assessment is a rapid screening tool for assessing cognitive impairment. It mainly assesses in the domains of attention and concentration, orientation, memory, visuospatial skills, memory, and language. And as you can see, our case presented initially had a total score of 4, which is quite low, and in the category of severe disability. We also applied an Edinburgh cognitive examination, which is a comprehensive cognitive screening battery. Again, it assesses in the domains of attention, concentration, fluency, memory, and language and visual spatial skills. It has a maximum score of 100. Any score below 82 is suggestive of cognitive impairment. Our case initially had a score of 7. We also, the patient also underwent a functional near infrared spectroscopy, which is a proxy marker of neuronal activity, which is measured by the amount of oxygenated hemoglobin versus deoxygenated hemoglobin in a neuronal cell and a neuronal area. So what we do is we emit a near infrared light, and we have an optic diode and a detector, which sort of this near infrared light is differentially absorbed between the oxygenated hemoglobin and the deoxygenated hemoglobin, which is then detected by the light detector, and the difference is measured. So coming on to the management, we started the patient on transcranial direct current stimulation protocol from 2020 onwards. The details of the same, the mechanisms as well as the evidence would be covered later by Dr. Heyman. Patient underwent 20 sessions, 2 sessions per day by using a conventional tDCS machine. A 32-channel EEG cap was used to identify the anatomical correlates. The 2 electrodes are placed in this procedure, and an anode through which the stimulus passes, and the cathode. So the anodal electrode was placed over F3 position, which is corresponding to the left dorsolateral prefrontal cortex, and the cathode was placed over F4, which is corresponding to the right dorsolateral prefrontal cortex. A current intensity of 2 milliamperes is delivered over 20 minutes. Here you can see the 2 correlates as per the EEG map. Post-transcranial direct current stimulation, an improvement was noted in both attention and concentration, recent memory, long-term memory, and as well as activities of daily living as reported by the patient's family members, as well as the improvement in irritability and aggression was noted. Clinical condition would gradually deteriorate over the next few months after tDCS was stopped, following which a repeat tDCS cycle would be given, planned once in every 5 to 6 months. So what we noticed was over the last 2 years, the duration between the tDCS cycles has been gradually increasing, and the overall cognitive function of the patient has been increasing as well. The patient has received a total of 9 cycles of tDCS from March 2020 to November 2025. So if we look at the life chart, patient had a history of road traffic accident on 2014, following which in 2020 the first session of tDCS was given. The red line denotes the clinical picture characterized by amnesia, irritability and aggression, emotivation, and difficulty in activities of daily living. As we can see, post tDCS session, the symptoms would decrease but would gradually return towards the baseline after a few months. So over the course of 5 years, we've noticed that the overall trend is in the downward direction. We also noticed an improvement in the global assessment functioning of the patient during that period. If we look at the assessment scores, in MOCA score, as we've noticed, the patient started at a baseline of 4 and has gradually increased in the scores post tDCS sessions, which gradually declines towards the baseline after a few months, following which we give another cycle of tDCS. And the latest score in November 2025 is 14, which has increased from a baseline score of 4. Similarly, in the Edinburgh scale, we've noticed that a gradual increase has been noticed, and with intermittent periods of deterioration between the tDCS cycles and improvement post tDCS. So, score of 25 is the one which measured recently, starting from a baseline score of 7. So these are the subscale scores of the patient, the latest score of the patient. And if we look at the functionally infrared spectroscopy findings, this is suggestive of the activation, baseline activation of a patient while performing a task during the FNIRS study. What we can notice is that the hexagons are suggestive of suggestive of the activation, and the color of the hexagons is suggestive of the intensity of the activation. The blue spectrum suggests a lower activation, while the red spectrum or the brown spectrum suggests a higher baseline activation. As we can notice, the first image is at the baseline in 2020. There was activity in the frontal region, but it had quite lower basal activation. And we can gradually see an increase in the intensity of the basal activation as we move along the years. The second image is from 2023, and the last image is from November 2025, where we notice that an activation, good baseline activation is also noticed in the right prefrontal cortex area. So this is suggestive of increase in oxygenated hemoglobin, a proxy measure of baseline, a proxy measure of neuronal activity, which is suggestive of neuroplasticity, which we can see in this index domain. So now I'll ask Dr. Hemant to present the evidence of tDCS in TB.
Thank you, Dr. Madin. Good afternoon, everyone. So I'll talk a bit about tDCS and then discuss the evidence. So starting with tDCS, this device is part of the non-invasive brain stimulation apparatus that we have, and it uses electrical current to generate electrical fields in the brain, which leads to, rather than directly stimulating the region, increasing or decreasing the excitability of the region. So essentially what happens in this, as compared to other mechanisms where higher amplitude of current are used, where the current directly stimulates the particular region. For example, let's say we are stimulating the somatosensory region, which can elicit, or motor cortex region, which can elicit a response in the person, which can be seen in either a motor or behavioral response. Compared to that, in tDCS, rather than directly stimulating the low amplitude current in the range of 1 to 2 milliampere, it changes the membrane's excitability. In some regions, the membrane is more excitable, and in some regions, the membrane is less excitable. I'll describe how the electrical current flows from the apparatus. So there is a stimulator that generates direct current through the use of battery, and this direct current, it passes through the anode towards the cathode. As you can see, the electrical field is generated in that direction, and this leads to modulation of membrane potential. And at the anodal region, there is an increase in excitability, whereas at the cathodal region, there is a decrease in excitability. This is the short-term effect that is seen. When the sessions are being given consequently for a particular period of time, it is seen that this leads to a long-term change, which is seen for sustainable period for months or years over their time. So there are several proposed mechanisms for the same. Some of these have been established to some degree, but there is no clear-cut mechanism that has been seen. Long-term potentiation, long-term depression has been proposed, along with change in BDNF levels or intercellular calcium levels. So there are several factors that influence how tDCS response can be seen in individual. So based on the mechanism that we have described, it is not necessary that each individual might see the effects as compared to another individual. So there are factors that are related to the tDCS parameters that are being delivered. There are factors that are related to the physiological functions of the particular individual, and there are parameters that are related to individuals in a particular community or a group. So a combination of these can influence the response that we see in particular individuals. Briefly about the tDCS device, how it works. So the simplistic model that we can see is one that is being represented. It comprises of three parts. One is the stimulator. It is mostly battery driven, and it provides direct current, which is then passed through the wires and leads, and then this reaches the electrodes. So classically, the electrodes that were used were sponge electrodes, and over the years, these have been developed into particular electrode conductive plates. Along with that, there is conductive gel. So the entire apparatus is called an electrode, which is in contact with the scalp region. This provides the electrical current to the scalp region. Now there are two types, at least minimum two electrodes are required. One is anodal electrode and one is cathodal electrode, and the current passes between both of these. Now, over the years, there have been several variations in the device. So the simplistic model has been built upon. Common variations that are more commonly seen is HD tDCS or home-based modality of tDCS that is also being used in the recent years. So the evidence that has been available with us right now, this suggests that the side effects with tDCS are largely milder and minimal. So the common side effects that are experienced are in the initial sessions, which are related to headache, tingling, burning sensation, where the electrode is in contact with the skull. Some rarer side effects have been reported in few case reports, like switch to hypomania or mania or precipitation of seizure, but this is much less compared to other neuromodulation devices that are being used. Briefly about the cognitive dysfunctions that are seen in traumatic brain injury. So persistent cognitive impairments are pretty common in traumatic brain injuries, particularly in the moderate and severe groups with rates up to 80% at times. These can involve any cognitive domain, but commonly involves attention, memory, processing speed, and executive functions. The current treatment modalities that are available does not provide a comprehensive improvement in the cognitive domains. Some pharmacotherapies have been suggested, but their evidence is limited. And cognitive rehabilitation interventions are the ones that are largely being used predominantly, and evidence and recommendations have been present for them. Newer modalities are being tried, like non-invasive brain stimulation devices, including tDCS. So the evidence of role of tDCS in traumatic brain injury has been being generated in the last decade. Recent reviews have suggested that it has shown improvement on multiple cognitive domains, prominently attention and memory, and they largely have reported that it is safe and tolerable for most of the patients. So overall, around 10 to 14 RCTs have been seen through particular reviews, and recent reviews have suggested that it is a feasible treatment modality that can be used for cognitive side effects in TBI. So some of the RCTs, what we can see from the available evidence in RCTs is that the excitable part or the anodal stimulation is provided at the left dorsolateral prefrontal cortex in majority of the studies. And this has been a convention, and we also use the similar design in our case. Along with that, a recent case study was also important, and it was also an interesting part where they have demonstrated that tDCS is being used as a home-based intervention where video telegraphic was used to deliver the tDCS at the home of the individual. So that this can be a potential in future, because many of the cases with TBI may have problems for coming and going frequently for the sessions. So this also holds an important promise. So why tDCS compared to other treatment modalities that are available? tDCS is a safe treatment modality. It has a growing base of evidence for efficacy. There is limited existing treatment options, and this can be a good alternative for the existing evidence. And it has a feasibility and newer evidence for easier portability. So with this, for concluding remarks, I request Professor Rohit Verma to.
Thank you. So it's not a new kid in the block. tDCS has been here from past 70 years or so. It was known as something else called as brain polarization therapy in 1960s, but it's something kind of reinventing the wheel. So now the understanding of how it works has found a newer kind of premise, and that is why it is being used currently in different scenarios worldwide. So overall, we have understood that electricity is the currency of the brain. While there exists psychotherapy, there exists medicines, there exists surgery in the field of psychiatry to change a person's emotions, cognitions, or behavior, there also exist machines which can also modulate that directly through interacting with the electrical current fields which are there percolating in the neurons, which are making us what we sense, feel, think, or behave. So tDCS is one such modality which utilizes that current flow directly, modulates it directly over the head, and brings forth changes, just as we have seen in this case of traumatic brain injury, for which there is nothing in the world as of now to bring forth some amount of change. This is a very simpler device. This is a very high-end device which creates electrical foci in a very, very precise manner, like a AIIMS kind of a thing. So in that sense, it gives you an opportunity to modulate the current in real time in different brain regions depending upon oscillations, how they are working. And the best part of it is that the effect versus side effect, of which we are always fearful of, always favored TDCS, even then more than pharmacotherapy, even more than any other neuromodulator technique. It works wonderfully in terms of side effect profile. But of course, the negative downside is that it doesn't work particularly well for everyone. So it's more of a personalized situation, which is which is to be looked forward. So overall, I can believe that these newer fields of intervention psychiatry bringing forth a lot of neuromodulated techniques are a promising future for psychiatry in the recent times. So future to me looks bright with brain stimulation. Thank you.
Sir, I think it's a very interesting case and in according to previous generation to the rehabilitation. So, I just want to ask two questions. One, how many cases are referred to psychiatry by the neurosurgeon post residency for this? Number two is that how many cycles one can give to these patients? So you have used 9 cycles. So if somebody is improving, showing the trend, 50 years or so.
So, sir, thank you, sir, for this very important perspective. So, all these neuromotor techniques work like medicines. They are not a one-shot answer for all. They require to exert their effect for a short run of period. So, when we talked about neuroplasticity, long-term potentiation and reflection, that suggests that when medicines work, they also tend to work for a certain period of time. After which, if you don't take the medicines, be it antihypertensive or any psychiatric nature, it will lose its effect. Similarly, goes for all the machines in that sense. Their effect will also be there for a shorter period of time. Post that, the effect will be lost because the primary etiology which was causing it, we have no understanding of, and it regenerates that pathogenesis back again. So, person requires the same modality of treatment back again. What we have seen with TDCS as well as in TMS and ECTs or other neuromotor techniques is, with time, when you give a modulatory technique, the period of remaining better extends over a period of time. Like this patient I've been seeing from past 7 years or so now. So over the years, I've seen that his inter-session intervals are increasing now. This time he's come after a year actually. So we see mostly research part more as compared to the clinical part.
We will start sending you patients.
So we can't do that. We are lacked by space for which we will ask.
We can continue.
We can continue forever. It's safe. That's the best part of PDCs.
So the referrals are
What you are suggesting is people are modulating it from clinic and they are delivering it at home.
Yes.
AIIMS so that you can.
That is the future that one is looking forward to. That home-based TDCs has a breakthrough approval in FDA, and by that device, one can modulate it on their own at home, but under the supervision of a psychiatrist who remotely supervises it. It's not something that one can just take it, because as he showed, the point where you are stimulating is crucial. If he mixes it or does it someplace else, then the whole story goes haywire.
So these instruments are available in US on Amazon. They are marketing as a cognitive enhancer. Even like anyone can order. The cost is around 20,000 to 25,000. So you can get cheaper as 20,000. 20,000 in Indian currencies. Yes. But these are not validated, or we are not sure about the reception.
The IIIMS or the more medical devices. I think we have run out of time. So that we can follow up with the